Good afternoon and welcome to the NHS Race and Health Observatory's webinar on compassionate and inclusive leadership and its role in advancing race equality in the NHS. I'm absolutely delighted to be chairing this session today. Ever since I picked up Professor Michael West's book on compassionate leadership, but also having engaged with these excellent panelists that we have with us today over my time working within the NHS. I have to say this webinar is being recorded. It's being recorded for the benefit of those that cannot join us today and for those that may wish to refer to it later on. I'm sure you will all agree that this agenda around leadership, around compassion and inclusivity within the NHS is both timely and much needed, because in the majority of cases, whilst our healthcare system is compassionate and inspirational and there for when we need it most, and we've seen that so vividly, I guess, over the last 18 months through the pandemic, it also embodies aspects that are imperfect and need to be transformed. One of those areas is perhaps leadership and workplace culture. Why? Well, because we know from evidence that having engaged staff, compassionate and inclusive leaders results in staff motivation and well-being, increased patient satisfaction and outcomes, as well as, of course, increased organisational efficiencies. These are areas that data and evidence tell us need improvement. These are areas that we will be hopefully talking about throughout this webinar. This is important for us, including, of course, us within the NHS Race and Health Observatory, because if we're in the business of tackling health inequalities, which we are, then we need a workforce and leadership that is fully supported and inclusive and compassionate. I'm delighted today to be joined by 4 inspirational giants of compassionate leadership and inclusive leadership. And I'll briefly introduce them before we go into the meat of the webinar. Firstly, we have Professor Michael West, Professor of Work and Organisational Psychology at Lancaster University. Professor Michael West has brilliantly encapsulated this topic in a must-read book called Compassionate Leadership, which I'm sure he will talk about in a moment. We also have Dr. Nikki Kanani, the role model medical director of primary care at NHS England and NHS Improvement. We have Lord Victor Adebowale, the inspirational chair of the NHS Confederation. And last but not least, Dame Marianne Griffiths, the multi-award winning, I should say, Chief Executive of University Hospitals Sussex NHS Foundation Trust. We will hear firstly from Professor Michael West and then move on to our panelists for their reflections and a Q&A session. So please do drop in your questions on this topic in the chat box throughout the hour, and we will pick those up, as many as we can, at the Q&A session near the end. But before we start, I'd like to invite my colleague, Sam Roger, who will begin by posing a question for you. So over to you, Sam.
Thanks very much, Habib, and good afternoon, everybody. As Habib says, we'll be hearing from the experts very shortly, but we wanted to start off today by getting a snapshot of what you think about compassionate leadership. So on the screen now, you should see a QR code and a joining link for a piece of software called Mentimeter. It's very simple to use. If you do have your camera phone ready, just open the camera and hold it up to the QR code, and that should take you straight through to the form. If not, you can go to www.menti.com on your phone or on your laptop and then enter the 8-digit code 37608860. I'll give everyone a second to do that. But the idea is we'll be able to ask you questions and get live feedback based on what you're saying today. Okay, hopefully that's long enough for everybody, and I'll move us along to our first question. What we want to hear from you today is one word that describes inclusive leadership to you. And as you enter them, they should appear by magic on the screen. We've got a few coming in here. Respect is there, listen, belonging, non-judgmental. One person saying not just race, authenticity, fair, equal, essential, warmth, transparency, responsibility, individuality. But very clearly in the center there, compassion, kindness, understanding, listening, and equitable coming to the fore. Thank you all so much for your engagement, and there will be, if there's time, more questions later. But for now, I want to hand back to Habib and the experts so we can hear what compassionate leadership means to them. Thank you.
Thank you so much, Sam, and that was very insightful. Now, without any further ado, can I please hand over to Professor Michael West? Over to you, Michael.
Thank you very much, Habib, and good morning, everybody. It's a huge privilege and pleasure to be able to contribute to this webinar this morning. And I want to say a big thanks to Habib and to Sam Roger and to Zara for enabling me to be a part of this. And also just an enormous bow down to Dame Marianne Griffiths and Lord Victor Adebowale and to Dr. Nikki Kanani. I mean, it feels really humbling for me to be with three such giants as part of this webinar, and so huge thank you to you as well. This last 18 months has been extraordinary and tragic and difficult for the whole of humanity, and it's a time, I think now, when it's really important we should reflect. Times of great difficulty are times where there's also opportunity for great learning amidst the tragedy and the pain and the fear. And I think all of us as organizations, as teams, as departments, as societies and as individuals, it's important we reflect on what we can learn from the last 18 months as we go forward. And I think that the key message that comes from the last 18 months is the importance of compassion in human society. But it's also important to remember that where we were in January last year, before this pandemic had really struck, our healthcare services, our workforce was in the biggest crisis that we've faced since the creation of the welfare state in 1948, with very high levels of staff stress. The highest that we'd seen for many years had been steadily rising, the highest levels of vacancies and very high levels of turnover, 1 in 3 nurses leaving the NHS within 3 years of joining, and similar patterns within the social care sector. And then the pandemic struck with all of the associated increases in work demands and fears and the anxieties that everybody had for their own lives, for the lives of their loved ones. And what we saw is what we typically see in human disasters: a huge upwelling of compassion in society, the compassion that all of you who work in health and social care showed for the people that you provide care for, the huge courage that you showed. And also we saw across society millions of people volunteer, formally and informally, to help. Millions of people volunteered to support the NHS and the vaccination programme. Millions volunteered informally to help. And as Rebecca Solnit's wonderful book, A Paradise Built in Hell, shows, that's typically what happens in disasters, contrary to what political elites believe, that people will be selfish, they'll loot, they'll kill each other. The vast majority of humanity is compassionate. Because compassion is a natural part of who we are. It's one of the 3 core emotional regulation systems. What is it? Well, for me to be compassionate to somebody in pain, then I have to do 4 things. I have to attend, understand, empathize, and then help. And attending means 2 things. It means being present with the other, and giving my attention. Nancy Klein's phrase is listening with fascination. And then I have to seek to understand the causes of their pain, not by imposing my understanding, but ideally through having a dialogue. And third, I have to empathize, have to feel with them without being overwhelmed by the feelings, because that gives me the motivation for the fourth element of compassion, which is the critical element, helping or serving. And neuroscience studies tell us that when we ask people to be empathic alone, that's associated with the activation of the various pain centers in the brain, because we're mirroring the other's pain. But when we ask people to be compassionate with that additional helping component, it's associated with the activation of reward centers in the brain. Well, why? Because over hundreds of thousands of years as a species, we've evolved this core emotional regulation system, one of our three emotional regulation systems. There's a threat system, there's a goal acquisition system, and there's a compassion system. And compassion is what enables us to connect with each other, to feel a sense of belonging, particularly when we feel threatened or unsafe, to create supportive social groups, families, so that we could evolve and survive. And belonging is so powerful in human behavior. We're more likely to die from the effects of loneliness than we are from the effects of, say, smoking. So compassion is a core way of responding to the pain of others. And we also know it's incredibly powerful in healthcare. We know it's probably, from all of the research, probably the most important intervention there is in health and social care, whether it's looking at compassion shown by anaesthetists prior to surgery, or compassion in the treatment of terminal cancer, or compassion in the treatment of long-term conditions like HIV and diabetes, or therapist compassion in the treatment of mental health problems. The effects are enormous. And also we know that being compassionate as a clinician or therapist has a positive impact on our own mental health and well-being. And we know that the effects are more powerful, for example, than aspirin commonly used in the treatment of heart attacks and of statins in the 5-year risk of a cardiovascular event. So the challenge for us is, how do we create the conditions going forward within our teams and organizations and our society indeed, where people will be compassionate towards those they provide care for and to each other? Because the point is, we can't go back to where we were last January. We mustn't go back to where we were a year ago, January. We must transform our teams and organizations for the long-term future, because the current way of managing the workforce has been unsustainable. And what that means in practice, of course, creating the conditions where people will be kind and caring and supportive to those they provide care for, and to each other, is about the culture of the organization. And Habib, I'm just wanting to check whether you can see the slides now on the screen. Can you see them clearly, Habib?
Yes, I can, Michael.
Great, thank you. So how do we change culture? Well, every interaction by every one of us every day is an opportunity to shape the culture of our teams and our organizations, by how warm we are, how kind we are, how irritable we are, how cynical we are, how aggressive we are, how compassionate we are. The ripples spread out. But we also know that the role of, from the last 100 years of research on culture in organizations, the role of leaders is particularly powerful. And I believe everyone who works in health and social care must see themselves as a leader. And what leaders pay attention to and what they monitor, what they focus on, and particularly what they portray in their own behavior, tells us what they think is important, and that tells us what they value, and therefore what we should value, and that's the culture of the organization in effect. So leaders must embody compassion in their leadership, and that means leaders paying attention to those they lead, listening with fascination, leaders seeking to understand the challenges that those they lead face in health and social care. Remember what I said at the beginning about levels of stress and turnover, intention to quit and vacancies. Leaders who empathize, who are emotionally intelligent with those they lead, and who then help those they lead. And this is not some new model of leadership. We've known for 60 or 70 years that these leadership behaviors are critical to effective leadership. Probably the research tells us the most important skill of a leader is listening to those they lead. And the most important task of a leader is helping those they lead to do their jobs effectively by helping to remove the obstacles and helping to ensure they've got the resources they need, the right number of staff with the right skills, the right equipment, the right technologies, the right training. And 60, 70 years of leadership research has shown us that when leaders in an organization, say in the private sector, generally behave in this way, that is related to customer service, customer loyalty, productivity and profitability. And in the NHS, we know from 18 years worth of staff survey data with over 500,000 people responding every year, that when leaders in a trust generally behave in this way, then that impacts staff satisfaction, which subsequently impacts patient satisfaction. When staff say generally their leaders don't behave in these 4 ways, then subsequently what we see is staff reporting chronic work overload, high levels of staff stress, which in turn lead to lower care quality, worse financial performance of trusts, higher levels of staff turnover, lower levels of patient satisfaction, and in the acute sector, higher levels of avoidable patient mortality. But this is not, absolutely not, some soft cushions and scented candles approach to leadership, because compassionate leadership is about delivering for the people we serve, the patients, the service users, the community, our colleagues that we work with. So compassionate leadership is about being effective and ensuring that our efforts are aligned around a core vision and a clear set of strategic goals. It's about ensuring that our efforts aren't being dissipated on petty quarrels across boundaries and unnecessary bureaucracy and unnecessary regulation, and that we're creating commitment. If leadership is not inclusive, then it's not compassionate. Compassion and inclusion are 2 sides of the same hand. They're about belonging. And belonging and inclusion are fundamental to human behavior. That sense of connection is fundamental to our life experience. If a child is excluded from her friendship group in the primary school playground, we know that it leads to inflammation of the central nervous system, which damages health. And we know that people from minority ethnic groups subjected to discrimination over the lifespan, that has a biological weathering effect. So inclusion is a moral issue and it's a health issue. And the great work of the Race and Health Observatory is bringing everybody's attention to recognise that fact. I think everybody who works in the NHS should have a basic knowledge of what the research tells us about discrimination, racial discrimination, and the effects on health over the lifespan. But it's also, inclusion is a performance issue. I've had the privilege of studying research healthcare teams over the last 30 odd years, and all of our research tells us that when you have teams with clear direction and alignment and commitment, that diverse teams outperform other teams in terms of innovation and productivity and effectiveness, whether it's executive teams or primary healthcare teams or community mental health teams or breast cancer care teams. We know that diversity is a performance issue in the NHS. We know, for example, that the top 3 predictors of patient satisfaction are, first one is work overload of staff. That predicts patient dissatisfaction. The second predictor of patient satisfaction is the extent to which there are cultures of equity and inclusion in NHS trusts. And the third is the effects of discrimination. The less discrimination that staff report in trusts, the higher the levels of patient satisfaction. And we know that patient satisfaction predicts care quality. We also know that leader representativeness in trusts predicts bullying and harassment and aggression and discrimination. The more leaders represent the staff that they lead in terms of ethnicity, the lower the levels of bullying and harassment and discrimination. And we know that when staff in NHS trusts represent their communities, when frontline staff represent the ethnic diversity of their communities, that trust performance in terms of care quality and financial performance is significantly better. And the factor that accounts for that is civility, because patients where that representativeness is better are treated with greater civility. So care quality is better as a result because of better communication, and so is financial performance. And that's based on a major study published now in one of the top journals in the world. So if leadership is not inclusive, it's not compassionate. And this last year has shone a spotlight on the disproportionate effects of the pandemic on the health and well-being of those from minority ethnic groups, which merely illustrates what we all already knew, but in the most tragic and desperate way. And also, the Black Lives Matter movement has focused attention on the centrality of these issues in our society and in humanity as a whole. And this applies in many different cultures. If you are a Hispanic person in Chicago during the pandemic and you caught the virus, you were 10 times more likely to die than a white person. So now is the moment when we must transform, I think, our cultures to be truly compassionate, effective, and inclusive. And we have to move away from these rigid hierarchical systems that actually reinforce discrimination and exclusion. The irony is the NHS has the biggest, probably most skilled and most motivated workforce in industry, that we continue largely to manage them through extended hierarchies and command and control. The most effective organizations in the world, regardless of size, usually have no more than 3 or 4 reporting levels. In the typical NHS trust, the reporting levels are in double figures. And the more reporting, every reporting level adds probably around 10% to bureaucracy. So we must, I think, a challenge for the future is to create more collective systems where we're not concentrating power in the hands of a few, but enabling everybody to feel empowered and that they have leadership responsibility and authority. And we also know that increases the sense of inclusion and values diversity greater. And it's about working also compassionately across boundaries if we're to respond to the challenges we face. Dealing with the problems of staff stress is beyond yoga. It's not about adding more mindfulness programs and yoga only to what we do and giving advice on exercise and diet and all of that. And I'm not in any way wanting to argue against those. They're fundamentally important to our health, but they don't address the underlying factors that cause staff stress in NHS and social care organisations. We know from, I've had the privilege over the last 3 years, first of co-chairing an inquiry, independent inquiry on behalf of the GMC into the health and well-being of doctors in the UK, and then last year an inquiry on behalf of the RCN Foundation into the health and well-being of nurses and midwives across the UK. And to guide our inquiries and recommendations, we used a well-established model of the core needs of people at work. These 3 core needs must be met for people to be well and to be intrinsically motivated. In other words, to have low levels of stress and not intending to quit. And those 3 core needs are the needs for a sense of autonomy and control, that we have voice and influence in our work teams, our organizations, that we work in cultures that are just and fair, not characterized by discrimination and exclusion and fear and blame and lack of transparency. And it's about ensuring that people have a sense of influence over working conditions and the shifts they work and how they work and who they work with, and influence over their rotas so that they can balance home and work lives. And again, a core need of people at work is the need for belonging, to feel valued, respected, cared for, included in our work teams and organizations, is just fundamental to well-being at work. We know that when people work in teams in healthcare where that have direction, alignment and commitment, that have a limited number of clear agreed goals, and where they meet regularly to review performance, stress levels are more than 50% lower. People are much less likely to be intending to quit. The more people who work in trusts, who work in teams in trusts with those characteristics that are inclusive and clear about what they're doing and meet regularly, the lower the levels of errors that harm patients, the better the care quality, the better the financial performance, the higher the levels of patient satisfaction. As I said, staff well-being is dramatically improved, and in the acute sector, much lower levels of avoidable patient mortality. So we must build back inclusive team working much better going forward in order to transform our teams and organizations. And the third is the huge importance of a sense of the need for competence or contribution, that the work I do makes a significant difference to the communities that we serve. And that's the key factor which is impeding that in our organizations is chronic work overload. It's like the pattern on the wallpaper we no longer see. We must address the issue of chronic work overload. And we see places like East London Foundation Trust, which has got a strategy of asking staff what they would reduce or eliminate. They've eliminated 85% of clinical audit activities in their quality improvement culture. So if we're not talking about chronic work overload, it's the #1 factor in staff stress, the #1 factor in staff intention to quit. And as I said, the #1 factor affecting patient dissatisfaction. It affects staff cardiovascular disease, addictions, cancers, diabetes, depression. So we must address this issue. And all of these are to do with inclusion, because when people are discriminated against from minority ethnic groups, their sense of autonomy is dramatically undermined, as is their sense of belonging, as is their sense of contribution. So going forward, we have to transform our teams and organizations by ensuring that we are developing compassionate leadership, increasingly focus on meeting the core needs of all our staff and creating inclusive cultures. And this is a sort of summary of the key points I hope I've made. It is about changing the genetic structure of our organizations and ensuring we're addressing these issues at the level of organizations as a whole and systems, of leadership, of teams, of departments, of individuals, and building equity and diversity and inclusion and compassion into all of the key cultural elements in our organization: vision, goals and performance, and so on. And I'm not going to go through all this, but it's about changing the genetic structure of our leadership so we achieve these things too. As Habib kindly said, I've had the privilege over recent months of completing this book on compassionate leadership, bringing together the brilliant work that's going on all around the country, and it's been hugely informed by the work of the Race and Health and Observatory and many others. And I hope you find it full of practical guidance and resources and wonderful case examples from health and social care organisations around the country and around the world. And a big thank you to Health Education Improvement Wales for supporting it, and the amazing Dr. Rachna Chawla, the one-person Swirling Leaf Press, and Mash Chudasoma, who did the brilliant design. And finally, a big thank you to all of you for listening. Habib, thank you very much.
Thank you so much, Michael, for such an inspirational talk, and it's very clear that doing more of the same will no longer suffice. And the evidence-based approach that you highlight in terms of transforming leadership and cultures for the benefits of our organizations and patients, of course, is robust and is very strong and undeniable. What we will do now is go over to our esteemed panelists for their views and reflections on inclusive and compassionate leadership from their own perspective. I will start with, if it's okay, with Dame Marianne Griffiths, if that's okay, Marianne. But before I do that, just another reminder, please, to the audience, if you have any questions for Michael or for Victor, Marianne or Nikki, please drop your questions into the chat box and we will do our best to answer your questions. I'll do my best to ask the questions and the panelists will do their best to answer the questions near the end. So if I can hand over to Marianne for your reflections on compassionate and inclusive leadership.
Thank you so much, Habib, and thank you so much, Michael. And honestly, a privilege to hear you speak, I have to say, on this really important topic. And I think the timeliness of this is really important, actually. And we were having a slightly earlier conversation about that. And I suppose for me, before I sort of talk about the specific topic, is just a kind of a recognition that I've been, you know, a CEO for a long time, for about 14 years. And I have to say that in the last 20 months, I've just never experienced anything like it. And the reason I'm saying that is obviously the pandemic, but of course it's not just the pandemic. There have been other variables that have fed into the burden that's being placed on our staff. But the burden on our staff now is huge. And it so makes a difference, I think, that I think your staff, and in my case it's 20,000 staff, believe that you care about them, you care about where they've come from, and you care about what's going to happen to them moving forward. And I have to say, you know, the stresses that they're under are simply huge. And I think it wouldn't be unfair to say, you know, the morale is probably at its lowest I've ever witnessed. People are tired. It feels sometimes on the front line that there's no light at the end of the tunnel. We hoped that would be the vaccination. It doesn't quite feel like that yet. And I just think, as I say, this is so timely to have this debate about what we do in that circumstance. So I'm just going to take a provider view. It's a personal view, and that's all I can give you about, you know, why I particularly think this is an important discussion point. And I suppose I come from it from 2 points, really. One, obviously, as a provider trust chief exec and on behalf of our organisation, our key goal, of course, is to provide outstanding care for all of our patients in a way that is intelligent, you know, obviously inclusive and deeply compassionate. And I've stressed the all because there is something not just internal to the organisations, but where equity and similar approaches for inclusivity have to be met, and that's to all of our patients. And, you know, I work across the South Coast, very different demographies, you know, range from really, you know, very high numbers of older people, much more on the west of the patch. But then you move to Brighton and you've got such considerable diversity across all what would be our protected characteristics. And, you know, high level of homelessness, addiction, the impact of that, and sometimes a population that the public would rather not see, if I'm being honest, but I do from my office out the front, in front of ED. And the whole point about that is creating, you know, a service that is holistic, is respectful, is kind, and does still make an effort about seeing where those people have come from and where they're going. And in some cases, they are going nowhere. They have no home. It's kind of really important that we get that right. And I do think that really matters. Then, of course, my second hat with this is as an employer of 20,000 staff. You know, I mean, I absolutely recognise that it's, you know, we can't deliver outstanding care for our patients if we don't absolutely foster a culture of excellence within our organisation that is grounded in compassion and inclusive values. I mean, that's the only way that you can do it, I have to say. And when I was kind of reflecting over the weekend in preparation for this meeting, I was quite trying to really genuinely think and picked up some of the points absolutely in Michael's book. But, you know, it was talking about, so how do you really grow a compassionate, inclusive organisation? You know, how do you do it, actually? And one of the things, which is very true for me, is you have to start with a bit of self-compassion and understanding. And I don't mean that's just about the chief exec. I mean, it's about everybody has to think about where they come from. You know, what were the drivers that got you there? What gave you your motivation? You know, there's such, because of, I think people are so passionate about working in health, that they're very driven. But there's also in that drive comes a bit of a, you know, a risk in some respect, which is about the be perfect risk, as I often call it. And one of the things I've learned, and I do mean I've learned, because I would have been exactly the same in my earlier part of my career, is to be a little bit kinder to myself about my own perhaps weaknesses. And when I don't get things right, I have to be honest. And I've had an interesting debate with my own chairman over recent years that I'm allowed one allowable weakness. And the point I'm saying that, and I tested a lot, and the point of saying that is genuinely you can't be kind to everybody else if you don't understand yourself and are a bit kind to yourself at times. I just do genuinely believe that. And that's to say, that should be filtered to all of us in the organisation. And people should be allowed that space to not be perfect, which I don't think is great, actually, as a way forward. And I suppose the ingredients then, again, going back to how do you create a compassionate culture and an inclusive culture. And it goes back to one of the things that Michael has said, which I just so really agree. It's this whole thing of active listening, but listening with authenticity. I think you use slightly different words, Michael, but I think it means the same thing. And you need to do that at all levels. You need to do it within your own direct teams. As for me, you know, we need to make sure that happens in specialties, it happens in divisions, it happens at hospital level in our case, you know, at a group level. And part of that is, you know, the things that come out of that is you begin to really notice and take, I suppose, take opportunities in any interaction you have to discover people, to be curious, to understand kind of, you know, their life stories. And it doesn't need to be, you know, it can be very simple, but actually to kind of hear that, because it's such a predictor of where people come and where they want to go and what the drivers are for them and what's important to them. And I think that really, really is important moving forward. There's some other things really as well for me that I know is important, certainly in an organisation like ours, which is the whole tone and way that you communicate. So the listening is part of communication, but it's in every which way that you do it's important, it feels to me, in driving that compassionate and particularly inclusive culture. And I don't think we always get that right, if I'm being honest. I think also for me, it's always taking an opportunity where you can, and there are so many of them, is to encourage, praise, you know, really celebrate lovely things and lovely moments that you hear throughout all of these things. And they're small, they're bigger, they're larger, but they're real things for people's lives. And I think that encouragement and recognition, again, feels to me to be really, really important. And I think the last one, and I didn't pick it up specifically, Michael, in yours, but something, again, perhaps it goes back to not being perfect, which I seem to be very comfortable with. But my point also is about being able to take criticism. And I think maybe it goes back to the way, you know, something getting defensive. And I really have had a recent one that's been very interesting for me. So you probably would have seen something hit the HSJ, you know, our staff are really tired. I got a letter from my surgeons. Unfortunately, it got leaked, but it doesn't make a blind bit of difference, really. The fact is, everything in their letter is real. You know, they're overworked, they hate cancelling patients. It feels awful at some point. And you can just kind of feel, oh, you know, there's actually, you know, you have to listen to people. It's not personal to you. You just have to listen to it. And you know, through that criticism process, you learn a lot and you think, yeah, that's absolutely right. And yeah, you're quite right. Maybe I could have handled that differently. I could have communicated better. And I can't just say how important that is, but it's hard for people. I do think it's hard. It's how we help people move forward on that, which I think is really important too. And then I was kind of thinking, you know, why is it so hard in organisations like our own? And I suppose the first thing is to say, people talk about culture as though it's one thing. It's really important that, you know, people like me absolutely do role model, but there are probably 100 cultures in a hospital, a single hospital actually. And I think it does go back, Michael, to what you're saying. And in teams, they can have cultures and, you know, specialties can have cultures. And I think it's the translation consistently through that myriad of kind of is hard. And it's hard to get that consistency through an organisation. Doesn't mean you stop trying. I just think it's quite hard to do. The consistency of message, again, needs to be reinforced, which I've mentioned. I still think we're using Luddite systems and processes to drive it, whether they're HR processes, recruitment processes, and even our talent management processes, I think, need to be really upheaved and done in quite a different way. And again, thoughts around that would be really welcome, I have to say. But if I'm being honest too, I don't think our regulatory frameworks and the systems always that we're operating in reward what I would call, the need for strategic patience. And you need patience to get sustained improvement. You need patience to get change in an organization. You can't press the button and it happens. And I don't always think we get given that patience. The benefits, if we get it right, are huge. And I'm not going to repeat them. I suppose I'd add one of my own, and we've all had it. When you've worked in a really good, supportive team, you get a nourishment from that just keeps you going through all the hard times. I have to say, I have that with my team, and it makes me come to work. And if you can remember when it wasn't like that, it's just horrible. So there's something about the importance of just wanting to go to work that comes out of this, because we spend such a lot of time at work. But I just want to end maybe on a couple of positives. 1 minute, Habib, and I'll be quiet then. There's a couple of just good things that have really happened for me that, again, when you get it right, it can be fantastic. I'm going to call out one of our Labour Ward matrons, one of the first BAME matrons actually on the Brighton side of our organisation, called Maggie Myatt. And she came to me with a proposition about if she was seconded out for a year, the things that she could do to really improve the equity of access for our BAME pregnant women, and of course our women within the hospital who are BAME, who work for us, and change it. And we have done that, and she's set up what we call the REAL program, which is, it's about whole equity that we can get across. It has been stunningly successful, and she does podcasts, and I watched her podcast over the weekend, which was the first ever proper antenatal. This isn't just about interpreting, but really, really understanding what our Arabic patients might need from an antenatal system that is different to ordinary. And it was inspirational to see how she did it. And that's just supporting somebody who is gifted, wonderful, and allowed to innovate. And I think that's just amazing. And the second thing I'll just end on, because I am proud of this, is again using the people who have the skills, which were our BAME staff, how we managed through their podcast, their leadership, everything, to get our vaccination program up to 90% for our BAME staff, which I think was really excellent in doing that, and doing it in a really helpful way. So just really supporting Michael's absolute take on this, few different words, few different nuances, but absolutely 100% think that's right, but still think we've got a long way to go.
Thank you so much, Marianne. And from my perspective, there's a long list of other inspirational things that I know you've been doing in your trust, which demonstrate very clearly the leadership that we need. So thank you so much, Marianne, and we'll come back to you for the Q&A session in a moment. But can I hand over now, if I may, to Lord Victor Adebowale for his thoughts on compassionate and inclusive leadership. Over to you, Victor.
Oh, well, thank you very much. And what can I say after such brilliant contributions from Michael and Marianne, both of whose work I really admire. I chair the NHS Confederation, which boasts and is proud to represent leaders like Marianne and others across the acute community, primary care, voluntary sector and other sectors focused on the future of the NHS and the population health system leadership. I'm a recovering chief exec myself. I used to run Turning Point, which is a very, I suppose it's a widely spread organisation. We worked with people at the sharp end of the inverse care law, i.e. those people in need of health and social care the most tend to get it the least. So this is what I'm going to say. The first is that Michael's book, which I haven't read from cover to cover, I got it, thank you, Michael, is an excuse remover. It's a wonderful statement of actually this can be done, this is how to do it. It's an excuse remover. Leaders need excuse removers. The second thing I want to say is that we must avoid we must avoid Bland's law in the NHS. Now, Bland's law may not be familiar to many people. listening or watching this webinar, but it was devised by Sir Christopher Bland, who was the Director General of the BBC, ex-Chief Executive of Birmingham, a man who's seen many organisations both as a consultant and as a leader, and he observed this, and I think it is true of the NHS in some parts. Bland's law simply states that the culture of an organisation tends to be inversely proportional to its stated values. Now, I say that because the NHS has a set of values and a set of which are ingrained in its history. Now, it is, by definition, caring. That's how it's got to where it got to. But we have to be honest about the fact that in many pockets, that isn't the culture that people perceive as valued, valuable, and implementable. And I always believe that you should start with discussing the things that are undiscussable. The future is decided by the things that you don't talk about, not the things that you do, which is why this conversation is so important. In a nutshell, compassionate leadership, in my view, is summarised very simply, and some people who've heard me say this before, sorry, but it's very simple. As a leader, you are responsible for leading all the people, all the time, everywhere. It's not difficult. The leader that's failing, in one sense, to leads some of the people, some of the time, somewhere, which incorporates the point about inclusivity, which I'm really grateful that Michael and others have mentioned to date. It is not rocket science conceptually to understand that is your job. It is to lead everyone, everywhere, all the time. It's no mean feat. So let me try and present what that means for the individual. And Marianne is a good example of this, and there are others, but frankly, there are too few. You cannot lead the system if you can't lead yourself. Now, leading yourself involves understanding your own emotional, psychological dynamics. It's not as straightforward as people think, but I'm a great believer. I'm a great fan of the work of Manfred Ketz de Vries, who pointed out that basically, leaders tend to have a model of the world in their head, which they play out on the stage of their organization. So basically, understand your model, understand how that works, because most organizations and the NHS, it's a complex adaptive system, right? I don't need to get into what complex adaptive systems are, but what you do know is that small changes make the biggest difference, often, in complex adaptive systems. What's the smallest impact that you can have in an organization? Well, it's actually how you communicate. It's what you say, what you don't say, and how you behave, and how you are perceived to spend your time. That is what changes. Organizations are basically conversation engines led by leaders who need to hold in mind the whole system all the time, knowing that who they are has an impact on everything. The term "a fish rots from the head" springs to mind in referencing the role of the individual. It is no mean feat, and you need help. And it's okay to ask for help. And it's why I refer to the practice of leadership in the NHS as just that. It is the practice of leadership. In other words, you need to be engaged in a practitioner group that can help you understand who you are, and how you impact on your system, by which I mean the organisation and the context in which it operates. To not see leadership as practice implies that you are the completed article. Seems to me a notion of staggering arrogance. If you are not learning, then you are not leading. And leading in that context is learning. It's learning on behalf of the system. So what does that mean? Well, often people have talked about listening in the conversation so far, and I just want to define that a little, because often there's a lot of listening, but if I tell you that I'm listening to you, it's meaningless unless you've got evidence that you've been heard. And Marianne's example of the work of her surgeons and the letters that they wrote is an example of that. It's like, if you haven't got evidence that you've been heard, then you haven't been listened to. It's as simple as that. And the act of listening, as Michael has pointed out, is not easy. It's not easy. The second thing you need to do is, it's about building teams that are credible, but teams in the context of the NHS actually are also about distributing power. And what I notice currently, particularly when the NHS is going through change, there tends to be a focus on power rather than change or its distribution. And it seems to me that a team is only effective when you can distribute power to it such that it can do something as a result that it couldn't do before. Now, I won't get into how you build teams in complex systems, but it's possible to do that, and there's lots of ways of doing it. But fundamentally, it's about transferring power. In the context of population health, which is where we're going, it means actually understanding the nature of the communities in which we exist. And so I think it's vitally important that we understand power and how it's distributed in teams, and how do you build teams that are aligned. And what we know about successful organizations is that there's an alignment between vision, mission, values, and practice. Right? So I've talked about the individual, talk about the teams. Let me just end by talking about the system as a whole. You know, there's lots of skills that individuals need to understand. And what I've noticed about the NHS, just before I go on to the system at large, is that we lack an appreciation of the kinds of skills that we take for granted when we talk about compassion. So one of the things I know that Marianne and others will have is more than one mode of intervening in a situation. Do you understand by that? So, you know, what I notice is that often there's only one mode of intervention by a leader in the NHS, which is prescriptive, telling people what to do, right? As though you know the answer. And if you don't know the answer, you tell them even louder what to do, which seems to me to be insane, right? Actually, there are at least 6 modes of intervention that you need to be cognizant of and understand: prescriptive, informative, confronting, cathartic, catalytic, supportive. It's not me that came up with that. I think those of you familiar with the work of John Heron will know exactly what I mean. So at system level, to conclude, what we've realised is, over time, rather sadly in a way, that the NHS is not a service in that sense. It's a system. It consists of many constituent parts, and in order to lead those parts, you have to be a system leader. Now, one of the ways in which the NHS avoids change is to adopt language without changing behaviour. So what I find currently fascinating is everybody talks about system leadership because it's the new lingua franca. And it's a bit like saying everyone has to change except me, right? But you cannot do system leadership unless you are a system leader. In order to be a system leader, you have to do the following things. 1, you have to learn on behalf of your system. Why? Because if you're the leader, the one thing that you have that most people who follow you, and we'll talk about fellowship all day, don't have is time. You're the one most likely and most able to choose what you do with time. So if you're not learning on behalf of the system, I can guarantee that no one else is. Secondly, you have to be able to see beyond the boundaries of your organisation in order to understand its system effects. In other words, just seeing the end of your trust car park as where your responsibility ends is not system leadership. It's about seeing the boundaries are porous with other systems and understanding that the impact of all that is on an individual, usually on an individual at the sharp end of the inverse care law. There's a reason why poor people have got most negative value transfer in their relationship with the health and social care system, i.e. those are the ones that have to go from pillar to post and post to pillar in order to get one service. It's because we don't have enough system leadership focused on the outcome for individuals. And finally, the thing that has to happen, and this is important, I think, is that the systems, the organisations within the NHS and social care system have to understand what it is that only they can do. And I say that because as we move into population health, some of the questions that we have to ask are fundamentally about what is my organisation here for? And what is its unique contribution to this system, such that we're enabled to get into dialogue with other parts of it? Because it's in the and that the creativity and the need and the understanding of the patient and the patient citizen is created. I'll end there. This is a fascinating conversation, which I'm sure will go on beyond the confines of this webinar. But it's just a real pleasure to be able to have the conversation with such learned people. Thank you.
Great, thank you so much, Victor. And what we may do is just go beyond the 1 hour slot if we can. But if people have to drop off at 1 o'clock, then that's absolutely fine. This is being recorded. But if I can go over to Dr. Nikki Kanani for her views, please. Thank you, Nikki.
Thank you, Habib, and thank you for having me. What a wonderful webinar so far. And in Victor's words, I'm already learning so much. Now, apologies from me. I am slightly short of breath after that dreaded lurgy from last week. So I'm going to try and keep it short, which might work with the timing anyway, Habib. But there are some things that have really struck me through the conversation, and actually also with the book. Now, unlike Victor, I've not read the whole book yet. I'm about halfway through, but I will reflect on it. But I just want to step back a little bit first. When I was listening to Michael at the beginning, and I was thinking, you know, what does his description of listening with fascination, understanding what's happening locally mean for me as a human, for me as part of a team, a primary care team, a vaccine team, for me as a GP? And I was thinking about I suppose it's a parable that my dad tells. My dad loves parables, and he usually tells them in Gujarati, and he comes back to certain ones, so he has a few favourites, and this is one of his, so just bear with me, and hopefully it will all make sense. He tells me the story about an old man who was planting saplings of mango plants around his house, and a prince came by and said, these are delicious mangoes, thank you, because the old man obviously passed across a whole bunch of the mangoes. And the prince said, how old are you, uncle? And the man said, well, I'm 80. And the prince said, well, you're planting saplings of mango trees when I came here, but you're never going to see the fruit of those mango trees that you're planting. Why are you doing all of this? And the old man paused and he said, those amazing mangoes that you've eaten came from the trees that my grandfather planted for my dad and for me, and now I'm planting these mango seeds so that my son and my grandchildren will be able to enjoy them. And of course, you know, the prince took that away, and I think the moral of the story is something like, you know, looking forward and looking after others. But what really struck me about that is, on page 138 in the book, if you haven't had a chance, please remember that there's some really practical tips for how you can be an inclusive and compassionate ally. The thing that really resonated for me is about owning your privilege and being able to pay it forward. So I want to just focus on that for a moment, if I may. I remember through many years of coaching, very early on, my coach, who's you know, quite a, I don't think he'll mind me calling him a senior white man. And I remember saying to him, you know, I'm a mum and I'm a clinician and I'm, you know, this and I'm this and I'm this, and I don't know which bit to be at any one point. And years ago, he said to me, but you have to be your whole self. You have to bring every bit of you to what you do, because only then will you be your whole self, your whole undefended self. And I'll come back to that. But also, that's the only way you can really own your privilege and pay it forward. And because for me, this is what this is about. This is what we can do. Being only ourselves, because that's only who we can be, leading from the head and leading from the heart, rather than often, and Victor alluded to it, and there's been some comment in the chat, a kind of control, command, heroic leadership that sort of drowns out what's really happening. Marianne described so well how our workforce is feeling, what it's experiencing, and that real need for self-compassion and self-care. My message to my team this morning was not work harder, go faster. It was stand outside because the sun is really nice, and sometimes we just need to experience that. And sometimes when we're scared or stressed or overwhelmed, we have to remember to not just use our head, but bring our heart to our work as well. Excuse me. So when we bring our whole selves to work, into our work, we not only create kind of a wiser leadership space, but we listen with fascination. And Nancy Klein was one of the first books that my coach gave me. We listen with fascination every day. And when we listen with fascination, we create safe spaces, and those spaces can be more inclusive. You're not worried about not sounding like yourself or being yourself if you're in a space that feels safe. And there's a conversation I've had with Victor many times. Even now I'll be in a room or on a Teams meeting and think, what is my place within this space? Am I able to be my whole self? And sometimes it doesn't quite feel like that, but that's why owning your privilege is so important. And we can do this in different ways. My primary care team is diverse and incredibly constructively challenging. They make me think, they make me look, they make me work differently. And being compassionate in the NHS, anywhere really, is about involving yourself wholeheartedly in what is happening, whether it's your team, your local population, or recent events. So when a practice was attacked in Manchester last week, as a team we had to come together. We had to together feel scared and shocked and frustrated and angry. We had to come together to understand what had happened and what we needed to do. It was our problem. And by distributing the problem and sharing the problem, we started to build the solution. We distributed the power as Victor. We built up something different, something exciting, because it was all of our problems. And we can see how being open and compassionate and learning really comes through. And I'm going to touch on the vaccine programme as well, because Marianne mentioned it, and I think it is one of our best examples. It is the biggest vaccination programme in history, but the most important part of its success was the ability to learn about what others experience and have experienced before the vaccination programme, that we had to work through and help support and develop and create spaces to increase vaccine uptake by targeted work locally, distributing power, listening and not telling, so that local teams had the space, the safe space and the autonomy to show incredible innovation and initiative in vaccinating harder to reach communities. And in fact, it's not just harder to reach, it's underserved communities, because we haven't worked out often how to reach them in a way that makes sense to us. And that's what we need to take away from the work in the vaccine programme. And you've heard about the examples of, really local, really nuanced work in local communities. The mosque in Blackburn that was open to everyone, regardless of faith. And the volunteers from the mosque were marshals, welcoming and supporting people, ensuring that people felt safe and welcome. Pop-up clinics in hotels where homeless people could come forward and without worry about a reproach if they were asylum seekers, but get a whole health and social care review. And wonderful examples where specialist clinics in Leicester and others as well, where specific venues and spaces were created for people with learning disabilities. And so sorry, the session was closed to the general public, and it was a place where people went to because they felt comfortable. They felt comfortable, not us, they felt comfortable. So 5 things that I want to quickly leave you with. First of all, that point about being undefended, that has been the most important thing that I have to remind myself, or sometimes every day, and we all will feel that, but remembering to bring our whole self, because that's only what I can bring. That's only what you can bring. So bringing your whole self and being your whole space, your whole self is so incredible to creating your space. Caring about each other, we have to move away from that command and control description, because caring for each other, that basic kindness, is how you build trust. And if you can build trust, that's how you create spaces and ways of working that really reflect what our population, what our teams and our workforce needs. And we have to do hard things. We are doing hard things all the time, as Marianne said, but we can do hard things in hard times in a human way. Falsely, as Victor said, be open to learning. I want us to learn every moment of every day that we are in this service. And finally, recognise what you can do for others, because like the old man planting the mango seeds, it's not for him, but it's for others and it's for future generations. So owning our privilege, paying it forward, that's the best gift that we have to share. Thanks, Habib.
Fantastic, Nikki. Thank you so much. Some kind of very pertinent and inspirational lines there, Nikki. So thank you. Thank you to all the panelists. I've got a few questions that have come in through the chat box, if I can open those up, if that's okay. Firstly, to Marianne, if I can direct a question to yourself. The question is, how can we support leaders to understand the balance between power, control, and compassion?
Great question. And part of that has got to be how we support managers in their development, in their training, in what's important, in what we measure. And I mentioned, I think something I feel very strongly about is this whole thing about including values in the way that we recruit and we measure, actually. And I think we do it very poorly overall. And even in a 360, who does the 360? Great question, and it's not always the right people who do it. So there's something, that sounds more punitive. My point is, though, it's about developing, recognizing, being consistent, having a compelling vision that does include that, and just being, absolutely relentless and driving it forward and continuing with it. And of course, where it's not being applied appropriately, to call it out.
Thank you so much, Marianne. And I guess linked to that, if I can ask Victor a question. Victor, a question has come in asking, with so much leadership training, why is leadership in healthcare still so poor?
Now, in answering that, you might be able to hear piped music, and I hope you can hear my voice over the piped music. I've had to move rooms. Okay, so that's a great question, actually, because, and I actually took part in the review of the NHS Leadership Academy, and I think there's two things. One, it's inconsistent. The leadership is inconsistent. Partly because we're asking the wrong things of our leaders and we're not supporting them to do the right things. And I don't think we've been clear about what good leadership looks like. It's left to an accident. Well, so if you've got a Marianne, well, great, good luck to you. It'll be fantastic. If you haven't, tough. And the third reason is that I don't think the sheep dip works. I don't think sending people on a course and sending them. My thesis, actually, my master's was on leadership in the NHS, and I can tell you now that most of the people that get to the top of the NHS haven't been on the courses they expect everyone else to go on. So I just think we need to rethink how we do leadership in the NHS, and I would argue leadership in development in place is better than the sheep dip. I think actually the top, by which I mean, Amanda and others need to be very clear about articulating what good is and modelling it for themselves, because they're part of the system. And three, leadership needs support. It needs to be in development. It needs to be seen as practice in the same way as surgeons or clinicians are practitioners that are constantly required to update, understand and learn on behalf of the systems. You need exactly the same expectation of leaders within the NHS. And without that, that's why it's patchy. That's why that question has to be asked.
Great, thank you so much. Okay, I think I'm unmuted now. Thank you so much. Can I say some final thoughts from Nikki, because I know Nikki has to go. We'll come back to the question for Michael in a minute. But Nikki, is there any final thoughts from yourself before you have to go?
Before I cough all over everyone. I mean, I could listen to Victor, Marianne all day, and Michael. So I feel very privileged. But if I just to Victor's point. This stuff is difficult, right? It's difficult to be in the system sometimes, but I guess what I want to remind people is that it can feel uncomfortable. Owning your privilege, recognizing your privilege can feel uncomfortable, but it's all of our roles to make this a different space, a better space, and a space that's more that's safer and more inclusive. So events like this coming together, recognizing that this is not unusual anymore. We are coming together in a way that is incredibly powerful, is absolutely key. Thanks, Habib.
Great, thank you so much, Nikki, and thank you so much for being on this webinar whilst you obviously are poorly. So thank you so much. We really do appreciate your attendance, and we hope you get better fast. Thank you. Michael, if I can ask you a question, this will probably be the final question because I know we are slightly over time. If there was one thing that people can take away from this webinar in order for them to become more inclusive and more compassionate in their day-to-day working, what would that one thing be?
So the first thing I just want to say, I just feel I've been privileged to be in a masterclass listening to Marianne and Victor and Nikki. I've made pages of notes about what they've said. What I'm going to say in answer to your question, I think is really challenging. We have to all start learning to be present with each other in our interactions. So when, whoever I'm with, as Nikki says, it's about bringing our whole selves to every interaction, and it's being present with each other in the here and now. And it's not some skill to learn. It's something that's natural to us. It's about remembering to be present with you, Habib, as I'm having this conversation with you, and letting just letting go of all those clouds of what's coming next, what have I got to do, what I didn't do well previously, and letting the sun come out of being present with each other and blurring the boundaries between me and you, because we connect. And when we connect by being present, by when I look in your eyes, I see me, and you look in my eyes, and we recognize each other. And that learning to be present, remembering to be present in our interactions is a way of enabling others to feel connected and ourselves to feel connected. And I have this deep experiential sense that the more we feel a sense of connection with each other, with the world around us, with the ecosystems, with the other species, with the planet, the more truly are we living our lives in a way that is fulfilling, it's authentic, it's honoring this incredible existence we have. And that's the challenge for every one of us, to create a more humane society and a humane world where we value our environment and we value each other, and we create a world that's far more loving and inclusive and authentic and honest and full of wonder than the way we currently create our world.
Thank you so much, Michael. And I cannot think of a more positive point to close this webinar because the hour, well over the hour is up now, and it's been a fantastic, rich discussion. Can I thank our excellent panelists, Michael, Nikki, Victor and Marianne, for your time and your inspirational input into this webinar. Can I thank the audience for attending and asking such important questions? I'm sorry we haven't been able to answer all of them, but of course we will have a recording of this webinar on the NHS Race and Health Observatory website. And can I also thank my excellent colleagues at the NHS Race and Health Observatory for making this webinar happen. If you would like further materials and information regarding Michael's work, then please log into the NHS Race and Health Observatory website, where we will have the information on there. Also, please see the link in the chat box for the NHS Race and Health Observatory monthly newsletter, which you can subscribe to with the latest information regarding the work that we within the observatory are doing. Finally, I guess today has been both a call to action, but also a challenge to leaders at every level, that's all of us, to have the courage to embody the compassion and the leadership that we need now and going forward. I hope you enjoyed the webinar. Thank you all, and goodbye.